Thank you, Chairperson, Professor Funamizu. Distinguished guests, colleagues, students, ladies and gentlemen, I'm Taro YAMAUCHI from Faculty of Health Sciences, Hokkaido University. Today, based on the recent WHO report entitled Preventing Diarrhea Through Better Water Sanitation and Hygiene, I'd like to outline the water sanitation and hygiene issues we face with a focus on diarrheal disease. Diarrheal disease is caused by the ingestion of pathogens, principally through fecal-oral pathways. As Dr. So mentioned, 3 separate but interrelated risk factors are considered as the main causes of diarrheal disease, namely drinking water quality, sanitation facility, and hand washing practices. My presentation consists of 4 parts. First, I'd like to briefly explain the methodology used in the report. Next, I talk about exposure and intervention estimates of drinking water and sanitation, as well as the prevalence of hand washing and related interventions. In part 3, I'll describe the mortality estimates related to diarrheal disease due to the 3 risk factors, as I mentioned. Finally, I'll present some suggestions based on the report. Let me start with the methods. Exposure estimates for drinking water and sanitation were based on the database of the WHO UNICEF Joint Monitoring Program for Water Supply and Sanitation, called JMP. The global and regional prevalence of hand washing practices was estimated through a systematic review of the literature. You can find a country-based database on the JMP website. The impact of interventions to improve poor water sanitation and hygiene issues related to diarrheal disease were modeled through meta-regulation analysis, drawing on data from 61 drinking water, 11 sanitation, and 42 hand washing studies. Then the global burden of diarrheal disease from 3 risk factors was estimated for 145 low and middle income countries for the year 2012, combined with key risk exposure and risk estimates corresponding to those exposures. Now let's move on to the first risk factor, drinking water. The data on the use of drinking water source are based on the data of the JMP. All 145 low and middle income countries are covered. The data are collected through nationally representative household surveys in which respondents were asked to identify the main source of drinking water used by the household. Drinking water categories. As shown in this figure, households were classified as using either improved on the left or unimproved sources on the right. The improved category was further subdivided into a piped on-premises category or an other improved category that included public taps, standard pipes, tube wells or boreholes, protected dug wells, springs, and rainwater collection. The Millennium Development Goal, MDG, target for drinking water was met in 2010, and coverage has continued to rise. In 1990, 76% of the global population had access to improved drinking water. In 2010, this figure had reached 89%, increase of 2.3 billion people. However, as evident in this map, the coverage is uneven. Drinking water, even from an improved source, is not necessarily free of fecal pathogens and safe for health. A systematic review and analysis estimated that globally, 26% of people drink water that is occasionally contaminated with fecal indicator bacteria. As you can see in the graph, here too, the situation varies between different regions. In the low and middle income countries on the right, the estimated population predicted to be exposed to contaminated drinking water ranged from 14% in Europe to over 52% in Africa. Thus, as demonstrated, drinking water supplies are often microbially contaminated. And in many cases, people may treat water at the household level to make it safer to drink. Studies on household water treatment from 67 countries have been compiled and reviewed, findings of which have been presented in this figure. This figure shows the results according to the 6 WHO regions. Household water treatment was particularly common in the Western Pacific regions and Southeast Asia region. Further, 4 types of water treatment methods are used in households. Boiling in gray is the most commonly used method, and it is known to be very efficient in reducing pathogens. However, the effectiveness for diarrhea reduction when applied in household has been poorly documented due to unsafe storage and handling, which is in turn leads to recontamination after boiling. Filtration in blue is very common in Southeast Asia and Western Pacific regions, whereas chlorination in yellow is more common in Latin America and Caribbean and African countries. The impact of intervention to improve poor water is shown in this chart. This meta-regulation focused on quantifying the reduction in diarrheal disease that could be achieved through different transitions from lower to higher service level categories. This figure illustrates the risk ratio with 95% confidence intervals. As you can see, the greatest potential health gains were found when moving from poor baseline conditions and improved sources to good water quality. For example, the risk ratio was 0.89, or 11% reduction on transition from an unimproved source to an improved one. Greater reductions are observed on moving from an unimproved source to one that is piped on premises, 0.77 or 23% reduction. Or more so, to household water treatments, 0.55 or 45% reduction. However, there is very limited data on systematically managed sources. Therefore, these figures are for reference purposes. This chart summarizes the proportion of diarrheal disease risk that could be prevented due to the transition. Note that among those using improved water sources, diarrheal disease could be reduced by 11% by switching to an improved water sources. Further, switching from unimproved water sources to piped water on premises was found to reduce disease more substantially, 23%. Finally, effective household water treatment, which includes boiling or filtration and safe storage, showed the greatest disease reduction of 45%. I'd like to summarize the drinking water risk. Shifting from unimproved to improved point sources of drinking water yields only modest health gains, 11%. This is because these sources are sometimes contaminated, or because water may become substantially contaminated before consumption, for example, during transport, handling, or household storage. Somewhat larger health gain can be gained by shifting to piped water on premises, 23%. Effective household water treatment combined with safe storage can provide significant protection against diarrhea, 45%. Now let's move on to the next risk factor, sanitation. The coverage of improved sanitation has increased from 49% of the population in 1990 to 64% in 2012, with almost 2 billion people gaining access to an improved sanitation facility during this period. Despite these improvements, 2.5 billion people still use unimproved sanitation facilities, and of these, 1 billion people defecate in the open. Based on these figures, it is unlikely that the MDG sanitation target will be met. As for access to sanitation facilities, households are classified as using either improved or unimproved facilities based on the survey respondents. Improved sanitation facilities are likely to ensure the hygienic separation of human excreta from human contact. They include flush to piped sewer system, septic tank, pit latrine, ventilated improved pit, VIP latrine, pit latrine with slab, composting toilet. Unimproved sanitation facilities are further divided into shared facilities that would otherwise be improved, other unimproved, and open defecation. Please note that this chart is misprinted, as improved but shared facilities should be categorized as unimproved. Multi-level modeling revealed that globally, 58% of people in the low and middle income countries use an improved sanitation facility that is not shared. As you can see in the table, Sub-Saharan Africa and Southeast Asia had a lower percentage of the same as compared to the other regions. Impact of the intervention to improve sanitation. A meta-regression was used to quantify the reduction in diarrheal disease that could be achieved by implementing sanitation interventions. Notice that the risk ratio of moving from unimproved facilities to improved on-site ones was 0.84, or 16% reduction, whereas it improved to 0.72, 28% reduction on moving to improved facilities, including sewered ones. However, note that only 2 studies were available on moving from unimproved or improved to community sewer. This one. Therefore, these figures are only for reference. This chart summarizes the percentage reduction in diarrheal disease risk. We found that a 28% reduction could be achieved by shifting from unimproved sanitation to improved sanitation. When sewage connections are excluded from the analysis, the health gains are smaller, but still significant, with an expected reduction of 16% in disease risk. In summary, provision of improved sanitation in households, flushing to a pit or septic tank, VIP, dry pit latrine with slab, or composting toilet, significantly reduces the risk of diarrhea. Indeed, increasing access to basic sanitation at the household level remains an important but overlooked public health intervention for preventing diarrhea. Limited data suggests that the provision of a higher level of service, which protect the whole community from fecal exposure, provides significant additional protection from diarrhea. Let's move on to the final risk factor, hand washing. Hand washing with soap after defecation or before the preparation of food has previously shown to reduce diarrheal disease because it prevents pathogens from reaching the domestic environment and food and their subsequent ingestion. Based on 42 studies conducted in 19 countries, the hand washing prevalence in countries and regions was estimated using multi-level modeling. Globally, 19% of people were estimated to wash their hands after potential contact with excreta. On the right, hand washing prevalence is generally higher in high-income countries than in the low and middle-income countries, around 15%. Interventions for improving hand washing after toilet or latrine use or before food preparation can be part of a broader hygiene promotion campaign. The relative risk for hygiene education, focusing on hand washing with soap alone, was estimated to reach 0.77, equivalent to the expected reduction in diarrheal disease risk of 23%. In summary, current hand washing prevalence is low, especially in the low and middle income countries, where the level of diarrhea infection is high. Indeed, large potential health gains could be achieved from its widespread adoption. Finally, I'd like to summarize the global burden of diarrheal disease that could be attributed to inadequate water, sanitation, and hygiene, both separately and in combination. The burden of disease was estimated based on the distribution of the use of different types of water sources and the associated risk of diarrhea, outlined in this presentation so far. Note that 502,000 diarrheal deaths that occurred in the low and middle income countries can be attributed to inadequate drinking water. Of these deaths, 88% occurred in Africa and Southeast Asia. Further, 280,000 deaths in the low and middle income countries can be attributed to inadequate sanitation. Similar to drinking water, both Africa and Southeast Asia had a considerably high number of deaths among all the 6 regions worldwide. A total of 297,000 deaths can be attributed to inadequate hand washing. A trend similar to that of drinking water and sanitation was observed. Both Africa and Southeast Asia had higher numbers of deaths. The exposures to fecal oral pathogens through drinking water, sanitation, or hygiene are not independent, and some people are exposed to multiple risk factors. Therefore, the total disease burden does not correspond to the simple addition of the separate burden of these risks, but is slightly lower. As a result, 842,000 deaths in the low and middle income countries were found to be caused by inadequate water, sanitation, and hygiene, representing 58% of the total diarrheal deaths. Diarrheal deaths among children under the age of 5 years have been more than halved from 1.5 million in 1990 to 622,000 in 2012. However, inadequate water, sanitation, and hygiene continue to account for 361,000 of these deaths, over 1,000 deaths per day. To conclude, I would like to stress on the importance of enabling universal access to at least basic level of drinking water and sanitation services. The WHO report also suggests that raising service levels to safe and continuous water supply and to connection to a sewage system are likely to have major health benefits. Thank you for your attention.
Thank you very much.